Lymphoma Voices podcast brings you a series of conversations around topics of interest for people affected by lymphoma, the most common blood cancer in the UK.
Hello, my name is Anne Hook and I'm the Publications Manager at Lymphoma Action. And I'm delighted to be joined today by Professor Andy Davies, who's Professor of Haematological Oncology at the University of Southampton, and Dr. Cathy Burton, who's the Consultant Haematologist at Leeds Hospital. And the reason for the podcast today is that as Lymphoma Action celebrates its 40th anniversary, we wanted to look back at treatment over time and also look forward to what treatment may look like in the next 40 years. So welcome, Andy and Cathy. Andy, could you tell me a little bit about your background?
Yeah. So I came into the world of lymphoma having trained as an oncologist, and I kind of got inspired by the people that I was working with when I came to learn about lymphoma. And this looked like it's an area that was, very interesting in terms of the progress in our therapeutics, our progress in understanding the disease biology, but also the fact that this was an area where we were seeing lots of advances and we had a kind of an ongoing relationship with the patients. And so I was really interested. I had some great opportunities where I was working at the time. And then it kind of got stuck really enjoying what I was doing in looking after patients with lymphoma.
And Cathy, can I ask you a little bit about your background?
Yes, so I'm a haematologist, having trained in Cambridge and in London. I did my first haematology job at Addenbrooke's Hospital and thoroughly enjoyed it, and therefore knew I wanted to continue in haematology. I was actually then at the Hammersmith Hospital, and it was a very inspiring time because that's when imatinib became available. So almost overnight, for the treatment of chronic myeloid leukemia, we went from transplanting patients to giving them a tablet. And I remember thinking at the time, I just hope the same happens in lymphoma, because that was my interest. So at that point, I then moved to University College London to work with David Lynch, because he was really one of the leaders in lymphoma at that time in the UK. And that was a very informative job. I did the clinical trials fellow post at UCL and really learnt about how clinical trials could help in the management of lymphoma and how they could then bring new treatments available to patients. I then, associated with that job, moved to Leeds to work in the Haematological Malignancy Diagnostics Service, because that diagnostic service very much supported the clinical trials work. And I really liked that interaction between the clinical trials being led in London at UCL, but then also the diagnostic work supporting those clinical trials from Leeds. And I sort of really learned how collaborative the lymphoma community was. So I've thoroughly enjoyed my career in lymphoma and hope it will continue. I think it's a really inspirational area of haematology. And I think as a UK community alongside Lymphoma Action, we're doing good work.
Cathy, I think I can, completely agree with the collaborative nature of the lymphoma community. It's really stand out, and I think that's excellent from a perspective of everybody who's doing the diagnostic work, everyone who's doing the sort of the pathological workup and the delivery of new treatments and new ways of treating patients, and all of us working together with the voice of the patient has been so important to the success of what we have done in the lymphoma world.
And Cathy, you've spoken about diagnostics and your career involvement in that area. Can you tell us what it was like about 40 years ago or less than 40 years ago? Because I know you haven't been working in the field of lymphoma for that long.
No, I'm not sure I can go back 40 years, but I think it's fascinating how it's changed. And historically, so before I was really doing it, it was very much based on morphology and then some simple immunohistochemistry to try and define certain sort of subtypes of lymphoma. But there were only sort of major entities like high-grade lymphoma, low-grade lymphoma, Hodgkin's lymphoma, based on that identification of Reed-Sternberg cells. As time has gone on, we're doing far more sophisticated tests now. So what's really changed is the whole molecular component to diagnostics. But I think, ironically, historically, we had sort of big chunks of tissue to deal with. Now, very much most patients, which is much better for the patients in that it's less invasive, but they have core biopsies rather than excision biopsies. So actually, the material we have to work with is much smaller, and therefore we have needed to refine techniques so that we can work on small amounts of tissue. And I think that sometimes has caused some problems. For example, as well, tissues are embedded in paraffin, and actually that's more difficult to do molecular tests on. And over years, we've had to develop the technique. So whatever medium the sample is in, we can process it. But I think what's really expanded really is the number of tests that we can do on each patient's individual sample, and therefore gain diagnostic information, which is also obviously very important to be able to treat the patient, but also prognostic information as well as how patients might respond to certain types of treatment. So as diagnostics as well as much sort of expanded as well beyond the pathologist, I would say. Now sort of bioinformatics, even sort of AI, digital pathology, there's a vast array of people, from the pathologist through to the scientist to the sort of computer-based scientists, really now all involved in lymphoma diagnostics.
I think the big thing in the 80s, wasn't it, was this realization that you could use antibodies to kind of paint the surface of the cells under the microscope, and you could kind of identify where those cells had come from. And I think that really opened the door, this immunohistochemistry, as we call it, for us to be able to identify that there were, in lymphomas, different types of cells that were going wrong, B cells and T cells. And over the sort of late 80s into the 90s, we were able to refine this, I think, much more. And I think that was really an important advent. And we realized that actually there was lots of different types of lymphoma rather than just us describing what it looked like under the microscope.
Yeah, I think that's right, Andy. I think, we really had very few entities, whereas probably now you're talking up to 100 different types of lymphoma, and that diagnostic process is just so important to make the right diagnosis for each patient.
I was invited to talk to a meeting of pathologists last week, and they were talking about even more subcategories of the different types of lymphoma that are being discovered or being described, I would say. And as you say, the field, with all of the new techniques that we have, is becoming more and more complicated, and the groups of different diagnoses is getting more and more refined, really.
I guess that refinement, does that have a big impact on treatment, Andy, as we go forward? And also looking backwards, have you seen a big change in treatment over that period of time?
I mean, I think, Cathy said, maybe 40 years ago, we kind of thought about it as Hodgkin's lymphoma, high-grade lymphomas, and low-grade lymphomas. And I think we had a fairly sort of blunt approach to the non-Hodgkin's lymphomas. We were using chemotherapy, and although we recognize now that there's great diversity in the different types of non-Hodgkin's lymphoma, I think we had one solution, and that was to give people chemotherapy, and the backbone of that was CHOP chemotherapy. And it's now kind of 50 years that we've been using CHOP chemotherapy. It's still much of the backbone for a lot of what we do today. And in Hodgkin's lymphoma, sort of going back 40 years, we were giving radiotherapy, but we were using much larger fields of radiotherapy at different doses, with the consequence that brought more early and late toxicities potentially. And also in Hodgkin's lymphoma, we were using chemotherapy regimens, and some of those were really quite toxic. And I think what happened over the subsequent years of the late 80s into the 90s was we recognized we could use chemotherapy that was perhaps safer to deliver and had less of that sort of long-term toxicity and had a better effect in terms of fertility. But really, we didn't have any targeted type treatments that we kind of talk about today and we use all the time. We just had the really very blunt tool of chemotherapy, and it was a kind of almost like a one size fits all. So there have been some really kind of major changes. Not only has there been the pathology that Cathy describes, but also the way we stage people with lymphoma. So the way we understand where the sites the lymphoma is affecting and the extent of the disease. And we've moved to the adoption of CT scanners, and really now the PET scanner has become pretty much our standard of care in a lot of imaging for lymphomas. But the key things, I think, for me, in the non-Hodgkin's lymphomas, and to some degree in the Hodgkin's, has been the development of targeted therapies, the introduction of antibodies which can recognize proteins on the surface of the cells and bind to the surface of the cell, and either kind of activate the immune system to help kill off the lymphoma cells, or actually to carry a kind of a payload, like a sort of magic bullet, directly to the surface of the lymphoma cells. And so the big thing for this was the development in the sort of late 90s of the drug rituximab. This was the first kind of monoclonal antibody to be described, and the first one actually to be approved back in 1997. And that was a really exciting time to be working in lymphoma. We were giving these drugs that really on their own could be very effective in people with relapsed lymphoma, but we soon discovered that when we added them to chemotherapy, not only did they improve the number of people who were responding to chemotherapy, but also the kind of the survival of patients being treated with chemotherapy. And that really has been kind of a revolution for us. And those antibodies over the years have become more refined. We've got a wider scope of antibodies that we can use, but also we've kind of got many more kind of targeted therapies, which perhaps we'll talk about a little bit later. Also touching on what Cathy had said, and I know Cathy, you'll want to talk to this, is really about us understanding more individual patient risk. So understanding the prognostic scores that we often calculate based upon clinical presentation to help us kind of work out what the best treatment is for the right person, but also to modify our treatments in some diseases according to the response that we have. And I think, Cathy, you probably, have a lot of experience of this in Hodgkin's disease, don't you?
Yes, that's right. So thank you, Andy. So I think exactly as you described when we were talking about the diagnostic things, how we use immunohistochemistry to identify certain proteins expressed. And so CD20, that's given us the target of rituximab, which we've now been using for, as you say, for nearly 30 years. It's given us polatuzumab directed against a different protein, CD79. And I think equally the same in Hodgkin's lymphoma, we know the Reed-Sternberg cells strongly express CD30. That's one of the sort of hallmarks of the disease. And then we have brentuximab, which can directly target that. So I think that is how we have therefore refined treatments. I think, for example, in Hodgkin's lymphoma, there's immune checkpoint inhibitors, and we can use those because, again, they sort of cause the T cells. We know, for example, in Hodgkin's lymphoma, it's actually quite a difficult diagnosis to make because there's actually very few tumor cells present, and you're often looking at actually the surrounding cells, the tumor microenvironment, which consists of lots of T cells. And actually some of the drugs that we now use, for example, in Hodgkin's lymphoma, are actually using that mechanism of activating the T cells to help attack the actual Hodgkin cells. So I think we've really understood from the biology, the sort of the tumor cells themselves, the microenvironment, and then certain targets as well in terms of how we can use different treatments.
So I think one of the kind of other key things has really been about our improvements in cellular therapies, transplant therapies, and the way we do that. And although perhaps the majority of people with the lymphomas don't need to have a stem cell transplant, absolutely the technology around this, both from using the patient's own stem cells or using stem cells from a donor that might be related or unrelated, has really moved on, and how we support patients through stem cell transplantation and how we've improved the effectiveness of stem cell transplantation has been a really important. I think one of the key things around this has been about kind of supportive care, and that's using antibiotics and how to optimally use blood and other blood products, and how to use growth factors to help support patients through some of these procedures to try and minimize toxicity. And I think that's been one of the really key advances. Antibiotics sounds a really simple thing, but our technology in antibiotics, our recognition that giving early antibiotics really matters and really saves lives, I think is also really important to the way we treat people. And of course, there's sticking on the theme of kind of cellular-based therapies. Of course, now we have CAR T-cell therapy, where we can engineer the patient's own T cells outside of the body to sort of turn on the lymphoma cells and to directly kill off the lymphoma cells. And there's a whole kind of new avenue of refining technology to make CAR T cells better, to make CAR T cells safer, and to perhaps use CAR T cells in some types of lymphoma earlier in the disease course. And this has been a massive landscape change in some types of lymphoma. It's perhaps been somewhat behind in some of the more rarer types, such as T-cell lymphomas and Hodgkin's lymphomas. We don't really have those technologies that are available outside of the research setting at the moment. But I think this has been a really exciting advance for us.
I think that's right. And then the addition of bispecific antibodies as well, working in a similar way in terms of activating patients' own T cells. I think that has really revolutionized the treatment of lymphoma. You know, we now have several actually bispecific antibodies for high-grade lymphoma. We have therefore numerous treatments really for high-grade lymphoma that we're beginning to bring forward in the treatment pathway. So for first line treatment as well as relapse. And we now also have bispecific antibodies available for some of the low grade lymphomas, for example, follicular lymphoma. So that really has changed the treatment landscape.
And I think, bispecific antibodies, these are antibodies that can be kept in any oncology or hematology pharmacy, and so can be delivered immediately, really, for patients, or when the kind of capacity allows us to do that. And I think, as you say, Cathy, we're seeing trials at the moment that are ongoing looking at incorporating bispecific antibodies much earlier into our treatments. And so we're thinking about how we might use these even as a first therapy for lymphoma, because that's probably where we get our best and our most durable responses. So I think these are really exciting times, and there's a rapid upstep in terms of development of so very many more therapeutics. The other area we've got is also what we call targeted therapies. And so these are drugs that can identify pathways that are overactive often in lymphomas, and they drive the cells to divide. And these pathways can be targeted with drugs, and very many of them are given as tablet therapy. You've heard of these drugs like ibrutinib, acalabrutinib, zanubrutinib, but we're using in certain types of lymphomas that can switch off the pathways that are telling the cell to grow and proliferate. And I think this has been a really important step forward. Although they're not necessarily free completely of toxicity, they don't have those classical side effects that we kind of associate with chemotherapy, like hair loss and mouth ulcers and that very high rate of infection.
And it sounds like you've got lots of options to offer people. Does that make it more difficult as a clinician when you have somebody in front of you deciding on what is the best approach for them?
I think the most important thing is that you consider all options. We have very much a team-based approach to managing patients. So patients are all discussed through a multidisciplinary team meeting where we look at the pathology, the radiology, and all the clinical information. And then I think it's discussing it with the patient. The most important thing is informing the patient and then making a shared decision between ourselves as clinicians and the patient. And I think the most important thing is thinking about the sequences and treatments, because as Andy said, we do have a vast number of treatments now, and it's just using them really in the right order. So ideally, we would give the best treatment first line, because we think that's the most important time point when patients need treatment. But we have to consider sometimes there are restrictions in terms of what's available to us through regulatory bodies. But I think the most important thing is that we're very clear from the outset how we plan to deliver treatment in discussion with the patient, and plan that carefully. And some lymphomas are curative, and this is all about first-line treatment and trying to cure up front. For other lymphomas, they aren't curative. This is really a chronic disease, and it's all about managing that, reducing the toxicity as much as possible, but at the same time giving effective treatment.
Cathy, I kind of wanted to pick up your bit about the importance of the multidisciplinary team. And I think this has really been something that has been really important in terms of the development of all of the facets of work that we do around lymphoma to optimize care for patients. And actually having all the people with the right expertise and the different expertise that they bring sitting down together, reviewing the diagnostic biopsy, reviewing the PET scans and the CT scans, the clinicians, whether they come from hematology or they come from sort of radiotherapy or they come from systemic therapies, etc. And everybody together, putting their heads together, and with the kind of the input of the nurse specialists, to really work out what we think the optimal approach is for a patient so that we can have a very informed discussion with our patients has been so important, I think, in terms of progress of our therapeutics.
Yeah, I think it's absolutely invaluable. And just one point you made, Andy, about the clinical nurse specialists, I think they're so important in the MDT and in the whole patient management. I have to say, Lymphoma Action actually sort of pioneered clinical nurse specialists, sponsored nurses, and actually the first ever CNS was based in Leeds. And it really did transform our service. And now really they're clinical nurse specialists in every lymphoma service across the country. And I think their input, I think quite frequently that patients say things to their nurses they wouldn't necessarily say to the clinicians. And I think actually getting their voice as well, I think is very useful, having the CNS sort of as a patient representative in that MDT. So I think, and also the CNSs, I think in terms of continuity, I think is excellent, and the support that they give to patients, both during the consultation, both when the patients have left the consultation room, when they're at home and in their own environment, and by email and telephone. I think that's a really good support network for patients.
Yeah, I completely agree.
I want to now focus on the future. And I know 40 years is an awfully long time, but can we consider what you think will be the biggest changes in the next 40 years?
Obviously, what are the key things we want to do? We want to improve the effectiveness of the treatments that we have. We want to make sure that we can deliver treatments with the minimal toxicity. And when we think about toxicity or side effects, we think about those side effects that happen in the short term. And all of those are kind of things that people are familiar with around perhaps some of the things about chemotherapy. But also we worry about long-term side effects potentially. And we want to make sure we can reduce those. And so for me, I kind of see that progress in terms of drugs, be they new ways that antibodies can work and target new areas, or new targeted therapies, or new CAR-Ts, or whatever that happens to be, will all help drive this stepwise improvement in the effectiveness of the treatments that we give for patients, both when they first present and when they relapse. Also, hopefully they can have less burden of side effects as a result. But to me, similarly, we also see changes in our radiotherapy techniques, and that will continue to improve. The technology behind radiotherapy is marching on hugely, and we're seeing smaller and smaller uses of radiotherapy fields with less and less toxicity. So I think that's all really important. But I think for me, it's about trying to understand better an individual patient's tumor and trying to understand better the underlying changes within an individual patient's tumors so that we can better target our therapy to an individual. And so that's kind of this personalization of therapy. And Cathy, I know that you are very interested in this.
Yes, I would agree with you, Andy. I think it has been our aim probably over the last 10, 15 years for this personalised medicine. And I think we have made some steps in the right direction, but I think there's still work to be done. And I think that's right. I think if we could really, at the outset, be able to sort of risk profile patients, be able to give them more information about their lymphoma, but also about how they might respond to therapy. And I think that's where we could really make some improvements. And I think in certain areas, we've already demonstrated that. But I think maybe in areas like follicular lymphoma, where there is very variable presentation of patients or variable disease courses, I think if we could be better in providing patients with more information, it would help the patient journey. I think as well, we just need to, as a group, incorporate everything that's happening sort of worldwide as well, and the sort of change of digital pathology, the change of AI. We very much need to move with the times and try and maximize that in terms of applying that to lymphoma management. I think there are different models that you can use to predict how patients, for example, might respond to treatment. I think going forward, I think we'll very much be using that. And, patients are becoming more and more informed about their own treatment and disease through the internet, and I think we need to work on that as well. And I think it's very much a shared role between the charity, between patients and their clinicians.
I guess there's a couple of other things, really, I think that we also need to think about how things may change. We are very good at doing scans at the end of treatment and not necessarily detecting any residual lymphoma on the scans that we do for patients, but we do know that patients may still relapse after what looks like successful treatment. And I think the great application of our new techniques from genetics that can help us identify kind of the submicroscopic disease and try and identify better which patients we may think are at higher risk of recurrence of their lymphoma, I think is going to be a big step forward. And really important that we think about this is about how we focus on living well after having had treatment for lymphoma. And we use this term sometimes, survivorship, but looking after patients for the rest of their lives in terms of reducing any long-term complication of therapy, I think is really important. And that's not only just physically, but obviously in terms of the psychological support that people need.
Do you see changes in the NHS? I mean, we've talked about CAR T-cell therapy, which we know is a very sophisticated and expensive treatment option. As more and more sophisticated treatments come along, are the NHS going to be able to cope with that financially and practically, do you think?
So I think that undoubtedly is a challenge, but I think we've already been challenged with that. Andy's talked about CAR T-cell therapy. Probably 15 years ago, we would never have imagined that could have been incorporated into routine NHS care, which it has. So I think the NHS does have the mechanism to which new treatments can be added. We have very established services, how we develop and deliver treatment. And I think, we can be reactionary to that. So yes, there are some financial challenges. Obviously, there are challenges in terms of delivery. But I think if you look at the UK and how quickly we started to deliver CAR T-cell therapy, for example, bispecific antibodies we were talking about, and actually they can be more or less delivered in every patient's local hospital. So I think there are challenges, but I think doctors and nurses and other allied health professionals are used to a changing field. And I think we very much, treatments as they come through, as a clinical body, we need to support those being introduced. And I think we work very hard with regulatory bodies, with the charities to ensure that any potential treatments are available for our patients. So I think as time goes on, I do hope, I think that some treatments and maybe some diagnostic techniques actually replace. Often there's just constant sort of additional things. And I think there's actually probably some improvements where we could actually be brave enough to stop doing some things because we don't need those anymore. But I think actually the general direction of travel as it has been over the last 10 to 20 years, I think we could continue to maintain over the next 40 years.
I mean, I think, the NHS is remarkably flexible and adaptable, and we've been able, as you say, Cathy, to respond to the changes in the technology and the therapeutics and being able to set up our services in order to be able to do this. And of course, we recognize that, many of these new therapies are economically challenging, but actually, what they are doing is they're improving patient care. And if you can prove that your therapies do improve patient care and patient outcomes or reduce toxicities, then the NHS has proven that it has the ability to absorb that kind of burden because, improving outcomes is really so important in terms of the goal. And yeah, it is challenging at times to change perhaps the way you work, and sometimes feel that the pathways may take a little bit of time to change. But actually, I think we've been really lucky in terms of the lymphoma world, in terms of the adoption of new therapies with improved effectiveness.
Yeah, I think what maybe will change is the sort of model of delivery of healthcare. So we've very much moved from the inpatient setting to ambulatory care, where patients can go home overnight between treatments, and that's really revolutionised treatments because we're not using so many hospital beds. It's much better for patients, and we're even moving to the point where we're giving, for example, CAR T-cell and transplants through ambulatory care. And I think ultimately maybe more care will move into the homes, things like bispecific antibodies. It may well be possible to do that. And obviously this is all much better for patients. So I think there will be a move probably from so much hospital-based care, maybe some more community-based care. And I think that will help reduce the pressure maybe on hospital beds, for example. And I think that's definitely a direction of travel that lymphoma clinicians are interested in.
And reduce the pressure on the hospital car park as well.
Very important.
You mentioned AI. Do you see AI just growing in usage, for example, with diagnostics, as we look to the future?
I think we should embrace AI in terms of where it can support what we do. I don't think it's going to replace us. I hope not. But I think there are elements of AI that actually could improve things, save a lot of time, I think would increase efficiency. So I think there will be models of AI that we can use. I have to be honest, I don't think we're there yet, but I would hope over the next decade or so that we use AI to increase really efficiency and information generated as opposed to actually replacing doctors, because I think you do very much still need that interaction between a clinician and a patient.
I think we have to absolutely embrace the technology that AI is generating in all the different facets of delivery of care for patients with lymphoma, and I think that can only be of benefit. And I think what we have to do is learn how we use this and learn how to do it safely to protect everyone's interests.
Do you think the patient's experience has changed over time?
And that's a really good and interesting question. I mean, I really hope that our diagnostic pathways have become more rapid. We do know that patients, if they present in the kind of the emergency situation, it's much harder to treat those patients than patients who present in a more kind of elective type way. So we've tried really hard to kind of raise the profile. I know Lymphoma Action has been absolutely instrumental in this in terms of alerting people to the symptoms of lymphoma. And then there are certain sort of rapid diagnostic pathways that have been set up between general practitioners and hospitals to try and speed everybody as quickly through the diagnostic pathway, getting their scans, getting their biopsies, seeing the right clinicians. Now, that doesn't always run as smoothly, and sometimes those pathways are very complicated, but actually that's, we've been really focused on trying to do that. And I think, for me, I think a lot more patients come to the clinic more informed about lymphoma. I think there's been a raised awareness of lymphoma, and there's more information available out there that people can access. Sometimes that's a minefield because there's a lot out there, and how you navigate that can be challenging. I think Lymphoma Action have absolutely led the way in making high quality information absolutely accessible to patients. But actually, as Cathy has said, we have changed the way we deliver care by shifting more towards the outpatient setting. But also, we think more about how patients can lead their own follow-up when they've completed treatment, and there's been more wide adoption of what we call patient-triggered follow-up, where actually patients don't need to keep coming back to the clinic for routine visits where they sit in the waiting room for a number of hours waiting for the doctor to become free, and actually that there's probably not so much value for the patient in that. And having pathways where patients can sort of report in symptoms and have sort of regular, more remote follow-up has been really important in terms of providing patients with more ownership of the disease and leading how they like their follow-up to be led, really.
Yeah, I think I would agree with that. And I think actually discharging patients from clinic is something we've put a lot of work into, that actually being able to say, look, we think you are cured of your lymphoma and off you go, enjoy the rest of your life. But here's some information about maybe potential long-term toxicity. So I think we've done a lot of work as a community and with Lymphoma Action to allow that to happen. And I think we're better at actually saying that from the outset. So this is your planned treatment over the next few months or years, and that we would plan to discharge you at a certain time point. And I think the majority of patients are very happy with that approach. And I think all the information that Lymphoma Action provides in terms of the booklet, some of the courses that they have beyond discharge, have been really helpful for patients. And I think that is a very, very positive step.
And I think it's ensuring that patients who do get discharged have the way of knowing to re-access the service if they need to. They know that there's the backup of clinical nurse specialists, etc., that they can contact if there are concerns that they have in the future. And I think things like innovation, like treatment summaries and some of the things perhaps to expect in the future are also really key to providing patients with as much information as possible about their disease, the treatment they've had, and the long-term follow-up of those.
I've actually got another couple of questions for you both. And as you're there, Andy, I'll start with you. What motivates you to do your job?
Well, that's a great question. I think there are very many factors that motivate me to do my job. I think, number one is to try and improve the outcome for patients. And that can be in very many different ways, whether that's giving a treatment that is potentially going to cure a patient, or actually just making sure that the patient has the best journey that they possibly can. So I've always been attracted to lymphoma because of that very sort of personal part of the work that we do, and really being able to help patients in all sort of aspects of this disease journey, which obviously they don't want to be on. But also the other parts of the job that motivate me are really the interesting understanding of the science as we pull apart the lymphomas and we understand the science much more. And also, I'm very much like Cathy involved in clinical trials where we are trying to improve the therapies and use new therapies for patients, or we perhaps just try and make therapies that we've had before safer, or perhaps give them in a different way, or perhaps we learn more about patients after they've had treatment. But clinical trials to me are really important, and you can put those different facets of the jobs together. And I feel very lucky and very privileged, along with working with a great team in the hospital and the university that I work, but also with collaborators across the UK. As we've said earlier, it's a great bunch of clinicians and scientists in the lymphoma world, both nationally and internationally. So there's a lot of things that motivate me.
And Cathy, can I put the same question to you? What motivates you to do your job?
I think it's a fascinating, challenging job, really, and I absolutely love the interaction with the patients. I love being able to interact with them, describe to them what condition they have, what we can do in terms of treatment. And I think it's so broad, lymphoma. So you've got low-grade sort of chronic diseases right through to patients who present through emergency, so very unwell. It's a real range from the young through to the elderly, which all presents different challenges. I think the underlying biology is fascinating, and we've just discovered so much over the last few years and know that we're going to in the future. So it's an ever changing and evolving field, and I think that's what makes it so interesting. There's always new treatments becoming available, and it is how we incorporate those into our hospitals and into the management of patients. So it's very fulfilling. I think every day you learn something new, you learn something from every patient that you meet. And I think the way that we work across the UK as a lymphoma community, within our individual hospitals, with our colleagues internationally as well, and with charities and with funding bodies, I think we all work together in the direction of travel to improving the management of patients. And I'm really proud to be involved in that.
If there was one message you wanted to give to people with lymphoma, what would that be?
That this is a collaborative joint effort to treat their lymphoma and to improve their lives as much as possible so they can live a long and healthy life.
Yeah, absolutely. I think the whole thing is that there is a lot of people in a very big team. Some of those you might meet face to face, like your nurse specialist, like your consultant, but also there's a huge sort of army of people behind who are doing lots of other parts of the work to be able to deliver the highest quality care. You've heard this saying, it takes a village, and it absolutely does take a village to treat patients with lymphoma. But I would really say that everybody's working really hard, and that the future is very bright in so very many aspects of the care and the treatment for patients with lymphoma.
Andy, Cathy, it's been an absolute joy. Thank you very much for your time and for giving us such an interesting insight.
Thank you.
Thank you.
For more information about lymphoma and the support we can offer to people affected by the condition, please visit the Lymphoma Action website at www.lymphoma-action.org.uk. Lymphoma Action. Inform, support, connect.